Idiopathic frozen shoulder. It's a condition that we really don't know the reason for. It's had lots of names in the United States. You say adhesive capsulitis. In the United Kingdom, frozen shoulder, and that's a term we use in Swedish as well, frusen skuldra. In France, you say capsulite rétractile, and stiff shoulder in Germany. Perhaps someone suggests that the term we should use should be contracted shoulder. It's a condition without any trauma or known disease behind the frozen shoulder. The patients get shoulder pain and stiffness. It is caused by contracture of the capsule. The patients have a marked decrease of range of motion, and the key clinical finding is passive limitation of external rotation. The X-ray is normal. In the literature, we find reports about between 2 and 5% of frozen shoulder in the population, but some state it's a less common disease, that too many not clear diagnoses have been included. The diabetics have an increased risk, 20%. There is a female predominance, and it's most common in middle-aged people between 45 and 65 years of age. It may be seen bilaterally, but not in both shoulders simultaneously. We really don't know the pathology behind this disease. About 60 years ago, Niviaser, Simond, and De Palma reported about the pathology. They found thick contractile capsule. They found extensive fibrosis, increased vascularity, increased cellularity, and lots of inflammatory cells. Lundberg, he wrote a thesis about frozen shoulder that he presented in Malmö, Sweden, 1969. He found a dense capsule and an increased cellularity, but he found that the cells involved was fibroblasts. It was a condition similar to that of Dupuytren's disease of the hand. Tim Bunker and colleagues had studied these frozen shoulder symptoms, and he has made histological and immunocytochemical findings. Studies. He has found active fibroblastic proliferation, changes in collagen, and he also found that the appearances are similar to that of Dupuytren's contracture of the hand. So he concluded that the frozen shoulder is a fibrosing condition, not an inflammatory one. As you study the shoulder when doing arthroscopy, you find a marked angiogenesis of the shoulder. There are petechias. The joint capsule has been reduced. There are thick scar tissue, and it's difficult to access to the inferior recess. And around the subscap, you have lots of loose tissue. As you look into the subacromial bursa, it's often normal, but often you see signs of mild impingement, but these patients are middle-aged. Occasionally you can find adhesions in the bursa. If you mobilize the shoulder under anesthesia and do an arthroscopy, you can see that the capsule of the infraglenoid recess is torn off from the bone reinsertion. The inferior glenohumeral ligament has been torn as well. It's down here. Natural cause. Frozen shoulder is a unilateral progressive shoulder pain disease. As the pain decreases, the range of motion starts to decrease. We have 3 periods of equal time. We have the first painful phase, we have the stiffening phase, and the thawing phase. And they are equal in time, and the disease is more difficult to put an adequate diagnosis to in the first phase before we can see the stiffening. Levine and Bigliani in 2007 reported 90% of recovery without operative treatment. Schaffer, he reported after a long time follow-up, average 7 years, a slight loss of function in 11% of the non-operatively treated patients. Other reports, however, have shown not as good outcome as that. Griggs and Hand and Carr found 10% failed to get better, 40% mild pain occasionally, and 40% had a measurable reduction of mobility. How do we treat idiopathic frozen shoulder? Well, we can do as we generally have done, no treatment at all, and wait for the natural course. We can give the patient physiotherapy, steroid injection. We can do mobilization under anesthesia, or you can do a release surgically, and that is nowadays arthroscopically. There are studies comparing different methods of treatment, but there are problems to do a proper study. They are often confounded by inadequate diagnosis. There's lack of controls. Then there is a wide range of symptom intensity and duration in this disease, making it difficult to compare. And you have to have a follow-up for at least 1 to 2 years. There are ways of treating frozen shoulder with physiotherapy, with stretching, exercise, and so on. But as when they are tested, Ryan and co-authors in 2005 made a randomized controlled study and found no differences between no treatment at all and treatment with physiotherapy. And Dirks reported even worse outcome. Patients that have intensive physiotherapy with exercises and stretching prolonged the natural course from 15 to 24 months and resulted in a lower constant score. Intra-articular steroid injection is often given, and it seems to give a short-term symptomatic pain relief in the first phase, but does not seem to influence the final outcome. And there are studies. Carrette and co-workers compared intra-articular steroid injection compared with or without physiotherapy compared to placebo injection with or without physiotherapy. 93 patients were included, and they had had frozen shoulder for less than 1 year. After 6 weeks, he found that steroid injection patients had a better result, and after 3 months, there still was a difference that group 1 and 2 with steroid injections were better functioning. But after 1 year, there was no significant difference. Ryans and colleagues made about the same kind of study with 80 patients that had symptoms for less than 6 months. And he found that after 6 weeks, the patients that had got steroid injection were better, but after 16 weeks, there were no significant difference between the groups with injections and from those with placebo injections. Then we have the surgical treatment, and it has been known that surgical treatment during the stiff phase may shorten the period of symptoms. You can do a mobilization under anesthesia, it's the most common method, or do, as we often do today, an arthroscopic release of the capsula and the adhesions. But there are few, almost no really good randomized studies. As you do a mobilization under anesthesia, you hope to shorten the length of the disease. Jacobs et al. Had 53 patients with frozen shoulder for less than 6 months, and they randomized these into mobilization under anesthesia or just steroid injection. And at the end point, they checked the VAS scale, constant score, and SF36, and they found no significant difference between the group when they had regular controls between 2 weeks and 24 months. Arthroscopic surgery has been more popular in the latest years. And the major cause of restricted shoulder has been told to be a contracture of the coracohumeral ligament. And it has been contracted and converted into a thick fibrotic cord. And Ozaki in 1989 presented a study when he released the coracohumeral ligament and found that pain relief and restored movement of the shoulder. There are a few studies about follow-up after arthroscopic release. Berg and co-authors, they treated 25 patients with frozen shoulder with a follow-up of 15 months. That were tested with the VASE scale, range of motion, and constant score. They found that the pain at night disappeared in 22 of the 25 patients. The VASE scale was decreased. The external and rotation and elevation motion was marked increased, and the constant score increased from 25 to 75 points postoperatively. But there is no control group, and we do not know how this differs from the natural cause or not. And we have another study by Klinger and co-workers that 36 patients with frozen shoulder with persistent stiffness after 6 months were treated with arthroscopic release. The follow-up was 18 months, and they found marked improvement in constant score from 29 to 66, and after 8 weeks, 75% had returned to work. But still, we don't know what have happened if we had given the patient no treatment. In summary, the majority of patients with frozen shoulder functionally recover, but 10 to 50% have decreased range of motion compared to the contralateral side, and 10% have stiffness resulting in dysfunction. Idiopathic frozen shoulder is a condition that can last from 1 month to several years with a mean duration of 12 months. And there is no evidence available in literature that steroid injection, physiotherapy, mobilization under anesthesia, or surgical arthroscopic release improves the outcome. So we need to do further studies to really know if we help the patients with arthroscopic release or other methods. Thank you.